one, which is no increased risk, but clearly there's a trend for it. So with this in mind, what I'm trying to allude here is that even a meta-analysis, which includes close to 3,000 or 4,000 patients, you can see many of these events are not common events, so it's hard to reach a statistical signal. And which brings us to what else can we look into to start to get a sense of how common is this problem. And Sai, just before me, mentioned on all the limitations of looking at databases, and I'll allude to that at the end in terms of all the pitfalls with this. But what I want to share with you is what is a nationwide inpatient sample. So this is a database that is part of the AHQR, and it's approximately 8 million hospitalizations per year and from 44 states. And it includes all types of hospitals except rehab hospitals, VAs. VAs are not included in there, and psychiatric hospitals. And they've been collecting data since 1988. And it really approximates 20% of the stratified sample of US hospitals, includes teaching hospitals and non-teaching hospitals. So the epidemiologists believe that this is fully generalizable to the US population, this data. Now, and this slide has been shown multiple times, Stavros Memsoudis from Cornell and Hospital for Special Surgery looked at this data and published this a couple of years ago. And it's quite interesting because we were talking about this when he started, when he published his data, I was in the midst of analyzing my data. So it was kind of a bucket of cold water on my head when I saw this published. I'm like, wow, whenever you think you have a good idea, somebody else beats you to it. But luckily, what Stavros didn't publish, what I'll share with you is mortality data, which I think is quite intriguing. So he looked at different years. He looked from 1998 to 2007. He looked at two surgical categories, orthopedic and general surgery. And you can see he looked at both emergent or urgent surgery and elective surgery. So there was a good chunk of non-elective surgeries, as you can see. And he used propensity score matching to compare OSA and non-OSA people. Now, in this database, mind you that OSA is being labeled as an ICD-9 code. That's all we know, that they have been labeled with OSA. How severe it is, whether they use CPAP at home or not, none of that information is available. Those are major limitations. With those limitations, he found that those who were labeled with OSA had increased risk of intubation, aspiration, ARDS, compared to match non-OSA folks. What we did was we looked at 2004 to 2008. So the reason we have 2008 and Stavros has 2007 is because every few years that goes by, they release a new year. And you have to go and buy this disc. This is not readily available. You have to actually buy those CDs of the data. And this is not research for the faint of heart. You need to have an infrastructure to be able to do this research. It requires special servers, special programmers. It requires statisticians. I could have never done this on my own. We looked at, and the reason we picked 2004 to 2008 was because I wanted a year in the middle, which was 2006, which was a publication of the ASA guidelines. And I wanted to look at 2 years before that and 2 years after that, see if there was any differences in terms of that publication. We looked at 4 specific surgical categories, and we only chose people undergoing elective surgery. So that's another difference we have with Stavros' study. And we looked at orthopedic surgery, prostate, abdominal, and cardiovascular. And you can see the breakdown here. By far, the vast majority of surgeries were orthopedic. After I saw this data, I realized I'm in the wrong field. But vast majority are knee and hip replacements. I don't know why the US population needs so many knees and hips. It's just beyond me. And remember, this is only 20% of US hospitals. So if you want to get the real number of how many knees and hips are replaced in the US, multiply it by 5. It's just insane. Well, maybe it's not, but anyway, that's my bias. So you can see that there is a big chunk of hip knee surgeries and a smaller proportion of spine. And then prostatectomy, these are hospitalized people. This is not ambulatory surgery. So many people who undergo minor prostate surgery are not included here. These are people who get hospitalized after prostate surgery. Abdominal surgery, mostly hemicolectomies or total colectomies or cholecystectomies. And cardiovascular surgery, mostly CABGs, but also a proportion of valve surgery. And one of the beauties of the nationwide inpatient sample is that it gives you in-hospital death. That data is actually there. Total charges is there. Now, that's not the same as total collection. You can charge whatever you want, but anyway, the charges are there. And length of stay. There's no data about what happens after the hospital with this database, so it's not a longitudinal database. It's just a kind of a cross-section. And then the way to come up with secondary outcomes, we did something similar to what Stavros did, but with a little twist. We looked at respiratory complications. We realized in the middle of our analysis that actually the timing of intubation can be extracted from this database relative to the admission and relative to the day of surgery. So we were interested in getting timing of intubation. And this is not intubation in the OR, obviously. This is intubation happening on an emergent basis. And then we were also interested in cardiac complications, such as atrial fibrillations, cardioversions, and coronary procedures. Now, you might ask me, why didn't you include myocardial infarction? The problem with myocardial infarction of coronary artery disease is that these could be conditions that people have in their medical history. And this is based on diagnostic codes. So, for example, when I look at pneumonia, people who undergo elective surgery do not get admitted typically with pneumonia. So I could, with reasonable degree of confidence, think that the pneumonia cause that I get here is incident pneumonia. These are new events. That's one of the problems with atrial fibrillation. I don't know if these folks had atrial fibrillation as a history or they developed atrial fibrillation. So as a marker, I looked at cardioversion because anything you bill for, they put it there. And coronary procedures. If they had a myocardial infarction, did they go to the cath lab, for example? And then, as I said, I was interested in what happened with the guidelines, whether it had any impact. So here, that's the other problem with the data set, because you could argue there's a significant underrepresentation of OSA, because many people may have OSA and they're not recognized. And you can see across the years that depending on which surgical category you look at, the coding for obstructive sleep apnea goes up. So it seems like there's more and more recognition. Obviously, this time span is too short to explain that this is some biological phenomenon. It's most likely related to the fact that people are recognizing more sleep apnea. Now here I'll show you some raw data in terms of no statistical manipulation or adjustment. This is just what it is, the data. So you can surgical categories on the x-axis, and this is emergent intubation. And you can see the percent of people who get emergently intubated is quite low. Now again, remember that the group that had the highest diagnostic code for obstructive sleep apnea was the orthopedic group. Around 6-7% of them were diagnosed with sleep apnea. So of the 780,000 hip and knees and spine surgeries, only of those who were labeled with OSA, you're talking about 30, 40, 50,000, right? 6-7%. Of those with OSA, only less than 4% got intubated. So these are quite low event rates. If you look at those who were not labeled with OSA, it's almost close to zero. So again, these are elective surgeries. Same with prostate surgery. Abdominal surgery is a little bit higher because you're getting closer to the diaphragm, obviously. And cardiovascular surgery, just by nature, it's a more complicated surgery. So I think these are expected. These are reported rates of CPAP or NIV use in the hospital. Now you could argue maybe people are not billing for this. Maybe respiratory therapy department is not using the code. That's possible. Although I could argue if there's money in it, why wouldn't you code? But regardless, I mean, these rates of CPAP use are dismal. This is 3%, 4% line, and these are people who've been labeled with OSA. Those without OSA is even less. Now, again, you could argue maybe people brought their CPAP from home, and that's why they're not being charged for that. It's possible. We have no way of knowing that. Here's data on respiratory failure. Respiratory failure was defined based on ICD-9 codes of ARDS, post-operative respiratory insufficiency, pulmonary edema, and one more code that we had. And again, you can see that it's increased without any adjustments in all surgical categories between OSA and non-OSA, being more in OSA group. Risk of atrial fibrillation also seems to be higher, at least in these two surgical groups, but without any adjustments, it did not reach statistical significance. Now here's risk of death. Risk of death, as you can see right off the bat, without any adjustments, it seems to be a little bit lower in the OSA group. Now again, look at the y-axis. Overall, the risk of death is quite low. With that said, it seems to be a bigger signal in the non-OSA group, and we'll talk about this, why this could be. Now we're talking about length of stay. Again, these are data that are accurately collected in this database, and you can see that length of stay unadjusted is slightly higher in the orthopedic group if they have OSA, but in the surgical, cardiovascular and abdominal surgery is a little bit lower in the OSA group. So then we said, okay, these are unadjusted data. What if we try to adjust for some confounders? If you remember Memsudis, Stavros, what he did was propensity matching. Here we're not matching. What we're doing is simply adjusting. What we're adjusting for is for simple confounders, age, sex, a comorbidity index, which can have its limitations, but it's better than nothing. Whether they were Medicare, Medicaid, private insurance, income quartiles, a geographic region of the hospital, whether it was a teaching hospital, if it was a weekend admission, year of the surgery, and what was the surgical procedure code. And just to summarize the data for you, if you look at the adjusted odds ratio for intubation, you can see at least in these two surgical procedures is quite high. The adjusted odds ratio is 14 and 10, and here is also statistically significant. If you look at non-invasive ventilation or CPAP use, is dramatically higher in OSA people compared to non-OSA. If you look at respiratory failure, also increased odds except for abdominal surgery, which is quite interesting. You would expect abdominal surgery would be higher, but that was surprising to me. If you look at atrial fibrillation, after adjustments for confounders that I mentioned, OSA becomes a significant risk after adjustment in all surgical categories. On the other hand, when you look at death, in-hospital death, this is just in the hospital. What happens at home, we have no clue. You can see that they all are below, well, these three are below 1, and the confidence intervals did not reach 1. That's why the p-value is significant. And for prostate, it didn't reach any statistical significance. Again, this is showing that people who were labeled with obstructive sleep apnea died less. Now, one of the reasons it took us 2 years to publish this data is because we weren't comfortable. I mean, I still have some degree of discomfort because one of my mentors who was working on this with me said, well, are you saying sleep apnea is good for you? And I said, no, I'm not saying that. So I was trying to understand the data of why this is happening. And it's interesting because in talking to Stavros, he was having the same problem. He noticed that mortality data was lower. That's why he didn't put it in the paper, because he didn't know what to make out of it. And I talked to another group that looked at hip and knee surgery that Francis and I talked about. They published this is from University of Virginia. Look, same database, nationwide inpatient sample. They published that in hip and knee, mortalities increased. So I emailed them. I said, are you sure you didn't make an error in how you code it? You know, sometimes you make this error in statistics when you're in the program, in SPSS or SAS or STATA, and then you just get the reverse odds ratio. And they said, no, we had the same problem. We noticed that mortality was lower. So we said, okay, let's not publish that. And let's just focus on people who are undergoing revised knee and revised hip. So they took out all the other first surgeries and they just reported revised. And those who were revised have higher comorbidities and they had increased mortality. So it's interesting because I was starting to feel very uncomfortable about this. So here's adjusted length of stay now. Here we're adjusting for confounders, and you can see that for orthopedic surgery, still OSA has a little bit increased length of stay, but this is, I mean, you're talking about, when I did the calculation here, is like 15 minutes. And that's one of the problems with database analysis. When you have 700,000 people, 2 minutes difference can give you a signal, which is statistically significant. So you have to be cautious in how not to overinterpret the data here. Here's total charges in $100,000. Again, you can see that the differences are $3,000, $4,000 between OSA and non-OSA. So again, then we started getting interested in this concept, in this aspect of the study about intubation. So what we did find out is that those who were labeled with obstructive sleep apnea, we looked at timing of intubation. And just for full disclosure, this data point is not available in every person in the database, but it's available for the vast majority. So what you can see is that in all surgical categories, but particularly in the orthopedic surgery, those with OSA were intubated much earlier than the non-OSA people. So 85% of them were intubated in the first day. This is the day of surgery, versus 55% of the people who were labeled as non-OSA were intubated on the first day, meaning the other 45% were intubated at a later time. So then the question that we ask is, well, what happened to these folks who get intubated? And let me walk you through this. So here on this side, you have no intubation, and here you have intubation, right? So these are folks who got intubated, and these are the folks who got non-intubated. So this is clearly a smaller group. And here we're looking at death. So if you were an orthopedic orthopedic patient, and then if you compare this group to this group, right, no OSA, if you're not labeled with OSA and you get intubated, risk of mortality is around 23% in orthopedic. On the other hand, if you're labeled with OSA, blue is OSA, right, and you get intubated, your risk of mortality goes up. But you see, it's not that dramatic. So they get intubated earlier, and when they get intubated, they don't die as much. The non-OSA people get intubated later, and when they get intubated, they're literally hosed. These are dramatic differences. So, and I'm showing you, the other one is abdominal surgery. So here's a summary of this point. In hospital death, if you were labeled with OSA and you got intubated, we have 4 surgical categories, right? Prostate, abdominal, cardiovascular, and ortho. The ranges of increased death was from 1% to 4%. So again, intubation is bad. Mortality goes up. But if you were labeled as non-OSA, depending on which surgical category you look at, mortality increased dramatically more. Here's looking at length of stay. Again, if you were a OSA patient here in blue, compared to an OSA patient who got intubated, length of stay went up by maybe a couple of days. But the non-OSA people, when they got intubated, length of stay went up dramatically more. Again, OSA, length of stay, if you got intubated, went up by a day, 2 days, 2.5 days. If you were labeled with no OSA, length of stay went up dramatically more. Same goes with total charges, same signal. If you were no OSA and you got intubated, charges went up by 60,000 to 100,000. If you were OSA, sure, you get intubated, charges go up. That's expected, but not as dramatic. And again, the other thing we looked at was pneumonia. What happens if you get intubated and you have OSA? What's your risk of getting labeled with diagnosis of pneumonia? And again, OSA, if they get intubated, pneumonia goes up by 2 to 4% versus 11 to 25%. When you look at, and this is, again, length of stay, no OSA compared to OSA, dramatically more increased length of stay if they get intubated. So there's something, again, this suggests that, and we can have a discussion of why this is, but this is showing a clear signal that those who were labeled with OSA who got intubated didn't have as worse outcomes than those who were non-OSA and got intubated. Again, the same thing goes with total charges. So the summary of the findings here is that OSA was independently associated with increased risk of pulmonary complications and atrial fibrillation. I did not see an increased risk with tracheostomy or coronary procedures or cardioversion. That's why I just said AFib. Intubation occurred significantly earlier in the OSA group. OSA was independently associated with decreased mortality, and there was mixed findings on length of stay and total charges. And in patients requiring emergent intubation, outcomes were dramatically worse in those without OSA, even after adjusting for confounders. Then when we looked at the 2 years before and 2 years after, there was absolutely no difference. So there was no signal that the ASA guidelines made some improvement in outcomes. So again, I borrowed this from Stavros, a recent publication that he had in the British Journal of Anesthesia, in terms of pitfalls of big database research. Again, there's risk for coding error and reporting bias, inability to ascertain whether OSA is present or not, and what's its severity, unknown if condition was present on admission, or the diagnosis of OSA was given because they got intubated. That we don't know. Lack of longitudinal data in this database, lack of information about obesity and opioid use and sedative use, again, lack of information about home or hospital CPAP use, or adherence, I should say, lack of information regarding complications after hospital discharge. So there's a lot of data missing here. Again, that's why obviously this is a cross-sectional analysis. You can just look for associations, but you cannot establish cause and effect. So again, in my view, what this suggests is that in OSA, the upper airway complications may be the main reason for respiratory failure. They're rapidly reversible. They get intubated early. When they get intubated, they stay intubated for a very short period of time. And they don't die as much when they get intubated. That's why we think it's mostly related to these effects. Or another possibility is that since they were labeled with OSA, the anesthesiologist or the treating team may have just had a lower threshold for intubating them. Although I would argue if that is the case, you would think they would do CPAP first. And why do they have reduced mortality? I mean, this is when we started kind of, smoking something and writing the discussion, speculating. So, we talked about obesity paradox. We talked about ischemia preconditioning. Maybe that's protective, just in the short term, not in the long term. But we speculated that it's unlikely related to better care since more OSA people develop complications. Because if they had better care, why would they get intubated more, right? So it's hard to say they got intubated and they got better care. That's why. Because I showed this slide once and somebody said, oh, we're doing an awesome job. And I said, well, I'm not sure. Unlikely related to additional monitoring since total charges were less. And keep in mind that it's not like they were dying more, and that's why charges were less, because you can die earlier and you'll be very cheap in terms of healthcare costs. They were not dying. And then while we were publishing ours, or it was kind of getting EPUB ahead of print, this study came out of WashU, Barnes-Jewish, so it's a single center, but a large population of around 15,000 elective surgeries between these years. And they also found that OSA was not independently associated with mortality, and they had 30-day and 1 year. What's interesting is that after 1 year, there was an association with mortality. So in the long run, as Dr. Parthasarathi showed you, OSA is not good for you. In the long run, especially if you have severe OSA, your risk of mortality goes up. So just to wrap up, in my view, what we need to do as a field is to understand which phenotype of sleep disorder breathing is at risk. I think the way we establish diagnosis of sleep apnea in the sleep lab by just simplifying it and saying an AHI, whether that is applicable to the anesthesia world and what happens in the immediate postoperative arena may not be applicable. An AHI of 10, in my view, could be mild, but somebody can have an AHI of 10 and have profound hypoxemia, and in an anesthesiologist's point of view, that could be severe. So we don't have a good metric for assessing severity, in my view. Does perioperative treatment of OSA improve postoperative outcomes? I think we need to, as Dr. Parthasarathi mentioned, we need data on this before it just becomes, routine standard of care, Sorry, I don't know why I skipped that. And I just want to show my last slide, and then we'll entertain questions. And again, another area that is concerning to all of us is how can we improve adherence to any form of therapy we come up with, be it oxygen if it's effective, CPAP, BiPAP, adaptive servoventilation, whatever we come up with, we need to have increased adherence in our patients. And then with that, I'll just want to acknowledge people who really helped me analyze this data, David Meltzer, Vinny Arora at the University of Chicago and their team, which is from the Center for Health and Social Sciences, obviously Frances Chung, who was a co-author with me, and my sleep fellow who just had her baby and she'll be back from maternity leave. So thank you. I think we have time for questions.
Questions for Dr. Mukhlisi and Dr. Parthasarathi?
Yes. That's a valid point, and we discussed that in our discussion, that's a possibility. The argument against that is that when you look at CPAP use, is very low in the postoperative period, and that's now I think available from France's new study, Peter's study, my own study, retrospective analysis, and other people have published that people don't use their CPAP. So I feel uncomfortable to say that people are really using CPAP very much, and that could have caused this. Now, the other point that you make, that perhaps the group that was labeled as non-OSA had a lot of OSA in them, that's certainly possible. The OSA group got more intubation, yes. Presumably, yeah, yeah. Of the group that got intubated, only 3% of them were coded for CPAP. It's possible, we don't know. Sure, yeah. Correct. But again, going back to Dr. Javaheri's point, I think we can't have both sides of, we can't be in favor, we can't use this data and say, oh look, OSA people get intubated more and they get more complications, so then say for that purpose, coding was correct. And then go backwards and say, well, for the mortality, the coding was incorrect. I mean, we can't have it both ways. So either the coding was somewhat correct or incorrect. So either the whole data is garbage, which is possible. I'm always open to that idea. Maybe the whole thing is wrong. Or maybe, so you see what I'm saying? I mean, we can't have it both ways. Oh, for sure, for sure. Yeah, yeah. I mean, from my practice, clinical practice, I would say that the vast majority of people who are on CPAP at home regularly, when they undergo elective surgery, do not bring their CPAP to the hospital. That's my experience. I could be wrong, but maybe it's my patient population. But so I feel comfortable saying that the vast majority of people are not using CPAP in the hospital. Yes. Sure. And this also suggests that maybe early intubation, the same way early CPAP could be useful, maybe early intubation is useful as opposed to if you just sit on it. So if they were labeled with OSA and they got intubated early on because people had lower threshold for intubating them in the recovery room, maybe that was something good, as opposed to if they would have just sat on it for a while. Yes. The group that, so you're saying that the group, whether the group that was labeled as no OSA, the majority of them did not have OSA? I believe so, but I published it, so I'm biased. So. Well, I adjusted for insurance. I adjusted for insurance, Medicare, Medicaid, private or self-insured, and I adjusted for quartiles of income. Yep. I mean, that's data we have. Yes. No, that's one of the problems. We don't have BMI data. It's possible. Yep.
If either of you gentlemen were diagnosed with sleep apnea preoperatively for an elective abdominal procedure, how long would you want to be on CPAP for prior to your surgery?
I wish I knew. If it was me,
Yeah.
I have the foggiest idea. I don't know. Um,
I would just take a wild stab. I mean, in the sense that we just did a randomized controlled trial on CPAP adherence promotion, which is not only behavioral therapy, but we also did a support and knowledge dissemination kind of a health services study. And we did it over a 3-month period. So if I were to, and we were able to show in a pilot study, we were able to show statistically significant improvement in adherence, and it was an average of about 4.5 hours for the entire cohort. So I would want to say that 3 months would be sort of the bare minimum that you want to start prior to surgery, if that tells you anything.
yes.
Say that, part of the reason the forest patients make it really better is that because they are, I think you alluded to this before, slightly, because these patients are already labeled as first saying they're better monitored, better information, because, they may even go to the, I don't know, either ICU or maybe like a monitor versus somebody who's not, labeled as first say those regular, post-operative beds. And so therefore, you got earlier intervention of these patients before it's doing better.
It's possible. It's possible. I mean, the question was whether people who were labeled with OSA were being monitored more carefully, and maybe that's why they had better outcomes. And again, we can have the same question that you said. I could argue I don't think they got better care because they got intubated more, but his argument was earlier that, well, maybe the fact that they could have gotten intubated the first 2-3 hours in the PACU. And so, yeah, we don't know. We don't know. Yes, Paul? Yeah. Yeah. Just so we are on the same page in terms of coding and how these databases work. So this is all ICD-9 code. So the coding hasn't changed in terms of what codes we use from 2004 to 2008. And this is not based on what you code for billing. So these, the hospitals that participate in these type of databases, the charts go to professional coders that sit in a medical record. Now, you could argue that's worse than us coding, but I guess what I'm trying to say is that there is some standardization on how they approach this. But the same argument could be made that if they approach it in the wrong way, then there is a standardized wrong way of coding. So, I mean, you could go both ways, yes. I agree, and I think the data suggests that, yeah, and the data, that's why we speculate in the study that the fact that they got intubated earlier, and when they got intubated, they stayed, we don't know how long they were intubated because there's no code for extubation. Because that's what the programmer asked me. I mean, he doesn't know medicine, so he said, why don't you give me a code for extubation? And I said, I wish I had one. We don't know. So, but the fact that length of stay only went up by a day and a half or so suggests to me that the intubation was not prolonged, which again brings up the point of upper airway complication.
Last question.
Identify yourself. Just kidding. Yep, I agree. I, Yep, yep. But let me throw out one other teaser before we wrap this up. I've reviewed two papers now for different journals. One is on, and both of them looked at people getting admitted to the hospital with pneumonia. A completely different group of patients. Admission for pneumonia to the hospital. One was nationwide inpatient sample, the other one was Premier, the one that you looked at. And both of them looked at OSA. These are unpublished yet, so I just reviewed them for a journal. Both of them looked at whether you had OSA or not. The hypothesis being that if you have pneumonia and you're labeled with OSA, you have worse outcomes. And both of them showed that those who had OSA got intubated more and died less. Two different data sets, different condition, pneumonia, coming with the hospital, OSA, yes, no. OSA, people died less. So I'm very confused, to be honest with you. So, yeah.
just want to say, I think we need to think the protective effects of PEEP on the lower respiratory system. We're so hung up on the upper airway and desaturation that if the question is, which group is driving the mortality numbers in these database studies? It's a group that got intubated. Who got intubated early? The sleep apneas got intubated early. So they got lung protective ventilation earlier. Of course, the mortality was better. So I think there's a total physiological basis for it. And just to put another nugget of information, the PETAL network, which is essentially the offspring of the ARDSNet group, there are a lot of applications that were submitted. As I was pointing to earlier, the effect of PEEP in preventing lung injury has not been done yet. And that's actually one of the proposals that we have put in. And that, I think, is very, very responsive because it's tantalizingly close data that suggests that the PEEP can actually prevent your pneumonia from progressing into a worse pneumonia or into ARDS. And maybe that's why the ones who got intubated, it's like saying antibiotics. If someone has a pneumonia, we know there's data there, there's quality data there, that the time to admission versus the first antibiotic being hung actually has an effect on mortality. So in the same way, the time to when someone needs to be intubated, if it happens earlier, of course that group is going to get protected. And I think the other thing that we need to not forget about is yesterday during the workshop, Dr. Sleet from Singapore presented this data where he took a picture of his compadre who's traveling with him on the airline. He took a picture and he said he did the stop bang on him and he was positive. And I think what we fail to realize is that clinicians, when they look at a particular patient, they have certain biases of early intubation in a morbidly obese gentleman with a size 24-inch neck. They're more likely not to extubate them. They're more likely to do tracheostomy on them. So there are all those inherent practice biases, which is essentially confounding by indication that cannot be dissected out in database studies. You can only adjust and match so much with propensity scores, but even after matching for propensity scores, it's going to rise up to the surface. I think physiologically, with the obesity paradox or with the protective effect of PEEP, together they can explain the difference. I wanted to share the slide on how the Europeans did the PEEP that actually worked. The teaser that sorry, there. So let me introduce you to the helmet mask. And so Paolo Navalesi was a big proponent of this helmet mask. So they realized in preparation for their trial that putting a CPAP mask on an individual, there was a huge adherence issue. So for their postoperative patient, they actually devised a mask. And so this JAMA paper, if you dig deeper, this is the interface that was used. So some of it may depend on technology. Just want to throw it out there. But it's pretty noisy in there. It's like a wind tunnel.
Thank you, gentlemen. So we'll break off and get back in 10 minutes.
Thank you all. My name is Girish Joshi. I'm a professor of anesthesiology and pain management at University of Texas Southwestern Medical Center. I'm filling in for Dr. Norman Bolden, who unfortunately couldn't make it because of family reasons. So I've been asked to moderate this session. So we'll get started. The first speaker is Dr. Roman Schumann. He is Associate Professor of Anesthesiology at the Tufts University School of Medicine. He's Vice Chair for Academic Affairs. He is well published, fairly extensively in fact, in anesthesia for bariatric surgery. I know Roman for several years now. He's currently involved in studies on sleep-disordered breathing in obese population. And his title of his talk is Anesthesia, Sleep-Disordered Breathing, and Bariatric Surgery. Thank you, Dr. Schumann.
Thank you, Girish, for that nice introduction. I would like to thank the organizing committee for inviting me, and also the speakers of the prior session for just outstanding talks. I think I have learned a lot and keep learning on the issues that we face. And a lot of the stuff that interests me has come out in bits and pieces here and there. In particular, the last two speakers brought up a lot of the things that I'm going to talk about. So hopefully it won't be too long a talk, and it's a boring title, but hopefully I have something to offer to you. Housekeeping first, I have no disclosures to make. The outline of this talk is here. Bariatric surgery update, I have one slide that concerns the surgery. Then sleep-disordered breathing and the post-operative course. A lot of that work is familiar to you, but I'll show you some data that we generated in a small study some time ago that didn't appear to make a lot of sense, but I'll show you what we found. Then there is always the bariatric surgery and sleep-disordered breathing-related post-operative complication debate. Then I have a lot of surprises and questions in my mind that we as a society can address and try to solve and should solve. And then there's the ambulatory bariatric surgery debate. So this is my slide on surgery and how it has shifted over the last few years. It is amazing that the lap band has really gone out of favor. I'm fascinated by the fact that our surgical colleagues can go ahead, and in the last decade or so, the lap band was, better than sliced bread for morbid obesity, and many patients underwent that procedure, only to learn that, well, these days we think it doesn't really work. What you really need maybe is a gastric sleeve, and I'll be interested to see in another 5, 6, 8 years if the sleeve works. What we do know is that apparently the gastric bypass really does work, but it also has the highest surgical complications post-operatively. So it's going to be interesting to see what happens from a surgical perspective. This is all familiar to you. These are basically the numbers that we have in terms of the prevalence of sleep-disordered breathing in the general and in the bariatric surgery population. So this is Mamsoudas, who gave us these data or summarized them in the New England Journal article. Lots of people are unaware that they actually have sleep apnea before they present. This is interesting that in our surgical population we have almost 40% of a prevalence with moderate to severe OSA, not just OSA, but actually the higher severity classification. And then our bariatric surgical patients, where I'm interested, have a very high unrecognized number when you actually test them for particularly OSA. This is the study that we did when I first got interested. This goes actually back to 2004. We never really published this stuff, and I'll show you some more data later on. So what we're looking at here is a study where we took patients to bariatric surgery, and then at the time, our patients usually had a prolonged PACU stay for one reason or another. And what we did is we actually placed a portable PSG on these patients to actually look at everything, sleep architecture and AHI, RDI, and desaturations and so forth. And so what you can see here, it's a small study. We had 45 patients, and we had a group of patients that had a preoperative PSG and with data available to us, and a control group without a preoperative PSG. Of course, they all had post-operative portable PSG data. And it's interesting to see that in the overall group, they all come in sort of at the same level when you look at that very, very small time frame in the PACU. When you look at the group that had preoperative PSG data available, they came in very, very high with a wide spread, as you can see here. And in the PACU, they dropped down to what you could consider a much better RDI. And, we were scratching our heads and, what's going on? Did we do something wrong? Or is it just that the PACU nurses actually are doing their job? They are slapping these patients and say, breathe, you're not breathing, what are you doing? So in that very busy environment of the PACU, it seems like our obstructive sleep apnea at first becomes better, which brings us back to the environment that we're afraid of, which is the floor. What happens there when there's not that much attention or monitoring in this population? Postoperative course, Francis gave us a lot of data on how the AHI develops postoperatively, and you can see here data that go for, in this abstract that she published, for 7 nights postoperatively. And then what was intriguing are her data back in 2009, where she actually looked at sleep apnea data under different anesthetic conditions. So it seems like whether you have general or regional anesthesia, there isn't much of a difference. The AHI tends to go up. Now, this is outside of the recovery room environment. I have gone ahead and looked at the postoperative complications in the bariatric surgical population. Now, this slide, of course, is way too busy. You can't really make much sense out of this, so I'm trying to summarize this. So just focusing on the bariatric surgical population, I found 8 studies that identified specific OSA and bariatrics related complications. And really the summary is it's a variable design and quality with limited useful conclusions in terms of complications related to obstructive sleep apnea. Now, Babak was talking about his landmark study on this large national database that he analyzed, and he also did the same thing for the bariatric surgical population, separately from that large group that he did. And the results that he just spent a long time telling us about hold true for the bariatric surgical population as well. So you do see an increased and higher incidence of AFib, respiratory failure, non-invasive ventilation use, and emergent intubations in the bariatric surgical population. And then there was one study that stood out because there was no correlation between OSA severity and post-op complications in this population. Now, that's a study that's important because it supports the other findings from those studies outside of bariatrics that somewhere in their write-up go into the detail of whether or not the OSA severity is or is not a predictor of postoperative complications. And it looks like the severity is not really a predictor of complications, which is incredibly frustrating because if it's an all or none phenomenon, where does it start? And I think clinically we have pretty much learned that most patients in the mild OSA group do actually quite well. So in other words, in AHI, in using that classification of greater than 5 up to 15 probably doesn't do a heck of a lot. But once you get into the moderate severe area, it's different. However, problem is that every now and then you have somebody in the mild group that runs into trouble as well. So it's actually a dilemma. And out of that, there are many questions that come out. So severity assessment of OSA is very heterogeneous in the literature. And most of these studies that have been done are retrospective. And then really the question is, if OSA severity, the way we do it now, using AHI or RDI, if that doesn't correlate with adverse outcomes to a degree that really helps us classify a risk, then what does? And what is it in the PSG data? There's a ton more stuff in there other than AHI and RDI, obviously. What is it that we should be looking at? Is there something that we can use that is better at defining risk and correlating a categorization with postoperative outcomes? So we need some additional information, and the question is, what is it? It brings me back to that study that we did back a while ago. So we went ahead and just analyzed or correlated the pre-op RDI with the post-op RDI, again, just in that small time in the PACU. And I have R values here that show you that the correlation is really not there. If you square that number, you come out to 0.26 or something like that. Now, it's a little different for the preoperative compared to the postoperative oxygen saturation nadir, where you can see a slightly better correlation, but that's still an R squared of like 0.5 or so. So we ended up going ahead and correlating the ODI with between pre and postoperative. Unfortunately, the number of subjects enrolled in this study was really just very, very small, but it seems to me like there's a signal here. You now have an R value that's really getting up there. You're looking at a squared value of something like 0.7. So despite the fact that here we had a small group of patients where the RDI in the PACU, first of all, didn't correlate with the preoperative one, but also got a lot better, was basically halved, the oxygenation data actually did correlate. So it seems like we're dealing with some kind of disconnect between the hypoxemic issue that these people may have and the AHI that we're seeing, trying to tell us something, I think, in terms of how to look at classification of OSA. There are further signals. Ahmad did this study in 2008 that many of you are familiar with, and he found that OSA patients using CPAP perioperatively spend a significantly longer time in the first 24 hours, so that very acute intervention period postoperatively with an SpO2 of less than 90. They had more hypoxemic episodes compared to OSA patients not using CPAP. And again, Frances did this study that was just published last year. She had it at the ASA in abstract form, where you can see a signal here on the first day where using CPAP perioperatively on the first day in that first acute phase doesn't work as well. So in her study that she just published this month in Anesthesiology, this is one quote. And again, I'm finding the signal here, although she told me that this result may have come because of several patient outliers. But it is interesting that in her study, clearly, where she used AutoPAP in OSA patients 2 days prior to surgery and then on the first 3 postoperative days, then in that group, you can see that you can control the AHI reasonably well. But we're really not there in controlling the hypoxemia that well. I think we have to look into that. Here is the study that Babak did with specific to bariatrics now. So it's a large cohort that that really gives us these where am I? Sorry. That gives us this information that puzzles us to some degree. How can this be? And then the general surgery study that he did. Another paper that we all found in 2008, Wang was looking at a different type of classification. And to me, it seems like maybe he has given us an impetus to do more research where we find better correlation between a more anesthesia, perioperative relevant OSA classification by using oxygen indices. So he created his own scale using ODI 4% and classifying, as he states here, into mild, moderate, and severe. And lo and behold, he actually does find that there is a correlation with negative post-operative outcomes. I think we have to find a different way of classifying AHI to make better progress with those issues that we're dealing with, which is basically a not well working ASA, OSA guideline that doesn't really give us what we need to identify the patients that we need to identify to improve their outcomes. The other study that intrigued me was this one that came out in 2012, whereby this sentence here I think is important because it basically states that that AHI is a very attractive categorization for all of us for OSI classification because it's relatively simple and we all talk the same language. To me, AHI is akin to BMI for obese patients. It's great because it's simple, straightforward, we know what we're talking about, but when you really try to come up with correlations, you realize that it's okay, but it's not that great because what really matters is the distribution of the fat. And we've learned a lot more about visceral fat distribution versus peripheral, and that there's more than meets the eye. So I think we have to sort of move away from AHI and go with different and new parameters. And I think what I'm mostly looking for is maybe a new concept, and maybe this could be it, which would be the chronic hypoxemic injury index, if you so will. We need something like that, I think, that moves away from what is okay, but just simply not good enough. And Sai's talk was fantastic in the sense that he showed that there is something like a chronic hypoxemic injury in the sense that you get this tissue injury that carries forth, that's already present. You heard